Thank you very much for the invitation to present today. I'm going to share some of my findings on COVID-19, mainly in Hong Kong, but I'll start by going back almost a year to the opportunity I had to work together with China CDC on the early data from Wuhan. And so in probably the third week of January, myself and a few other colleagues flew to Beijing to work together on some analysis which was published in the New England Journal of Medicine. And one of the most important findings in that study was an estimate of the reproductive number, because that tells us how fast is COVID spreading, and in this case in Wuhan. So we looked at the earliest data on cases dating back as far as early December, and we estimated in this particular analysis that there was an exponential rise in particularly in the non-linked cases, the cases not linked to the seafood market, and the doubling time was 7.5 days, and with a serial interval of also about 7 days. From that, we got a reproductive number estimate of about 2.2. There were other studies being done at similar times, estimating the reproductive number in the range of 2 to 3. And so what that basic reproductive number means is, in a population where nothing's being done, maybe in a city like Wuhan, where nothing's being done, no control measures, one case of COVID on average will transmit to 2.2 others. And so as time goes on, as the generations proceed, we'll see more and more and more cases, initially very small numbers, but not after too long, we'll see rises to the tens and then hundreds and then thousands and then tens of thousands and so on, unless something's done, of course. And what I'm going to show a bit later in my talk is how the reproductive number can change over time because of the impact of control measures, maybe. And one of our objectives in public health control of an epidemic like COVID is to get that reproductive number down below 1, because if one case is infecting less than one other person, then as time goes on, the epidemic number, the numbers of cases will slowly decrease and eventually go down to 0. One of the other estimates in that paper, which was quite important, shown at the top of the forest plot on this slide, is the incubation period distribution. And that's important to us in Hong Kong because of our quarantine period. So we estimated the incubation period was about 5 to 6 days. 95th percentile was about 12 days. That means if there's a group of people infected, let's say there's 100 people who've been infected today, on average, their symptoms will appear after 5 or 6 days. The median is actually about 5. So about half of them will have symptoms within 5 days. And about 95 out of those 100 people would have symptoms by 12 days. So when we set the quarantine period of 14 days here in Hong Kong, people arriving into Hong Kong from overseas, they're put in quarantine for 14 days. That's because we think there's a very, very small chance that they'll have symptoms beyond that 14th day of quarantine. If they were infected just at the airport before they left their country of origin, coming to Hong Kong, then still there's really a very, very low risk that they might have symptom onset after they've exited quarantine. And of course, the virus shedding might start before the symptoms appear. Having said that, when I'm talking about quarantine, of course, if someone's coming to Hong Kong now from mainland China or from Taiwan or from another part of the world where there's really no cases, New Zealand as well, I'm not sure that quarantine of 14 days really affects the risk, because the risk is still 0 that they're going to bring COVID into Hong Kong, essentially. Certainly when we compare to the risk of people bringing COVID into Hong Kong from Europe or North America or other areas where there's really a lot of infections right now. So I think in the coming months, we may consider maybe a risk-based approach to quarantine, where, of course, we'll have a 14-day quarantine for people coming from high-risk areas of the world, currently Europe and North America, and also some other parts of the world, actually. So maybe we can shorten the quarantine period for other places, like we do for mainland China, for Guangdong province, sorry, where we just test on arrival, perhaps, or just let people come in without quarantine. One of the interesting observations that I'm working on right now, though, is a more in-depth analysis of the incubation period. And there's actually an issue when we come to estimate incubation periods, and I'll try and explain it in a simple way. So when we look at the beginning of an epidemic, we have a small number of cases a few weeks ago, more cases last week, and even more cases this week. The numbers are rising. If we look at who the cases are today and how their incubation periods look, we're going to tend to see today, short incubation periods from people who've been estimated quite recently, and longer incubation periods from people that were estimated longer ago. But if there was a lot more people been infected recently than there were in previous weeks, because the epidemic's increasing and the numbers are doubling every week, we're going to have a biased estimate of the incubation period. We're going to have more people with short incubation periods, kind of not representative. And we're going to end up with shorter estimates of the incubation period distribution than perhaps we should. And so we find this is in the bottom left panel here, that if we look at incubation period estimates that were made before, on studies, on data that were collected before the peak of an epidemic, mostly in mainland China, it's about there's about 5 days mean. And if we look at studies that were done on data collected after the peak of the epidemic in mainland China or somewhere else, the mean incubation period is actually longer. It's about 7 days. So it's a 2-day difference. And the 95th percentile is also a little bit longer. It's getting closer to 15 days, actually. And so I think we might have a better understanding of the incubation period distribution after we take these potential biases into account. So I'll say it one more time. If we look at people's who show symptoms today or this week, and the numbers of cases have been rising over time in recent weeks, we're going to have today a lot of incubation periods from people with short incubations that have been infected recently, and we're going to have a smaller number of longer incubation periods from people who are estimated longer ago, because there's not so many of those people in our epidemic. And as we approach the end of an epidemic, as the numbers come down, it's the opposite. So we'll start to see longer incubation periods from people who are estimated, who were infected longer ago, and less short incubation periods. So I should clarify, when I say here, the mean before the peak and after peak, the after peak is not the correct estimate. It's going to be somewhere in between. It's going to be maybe 6 days. And the 95th percentile of 14 days looks actually like a pretty good assumption, pretty good approximation. One of the other things that we worked on very, very early in the pandemic was pre-symptomatic infectiousness. We'd heard anecdotes from mainland China that there were cases where infections outside of Wuhan couldn't be explained unless there was pre-symptomatic transmission. So, for example, there was a businessman from Wuhan, went to Beijing for a meeting, went back to Wuhan, asymptomatic, developed symptoms a few days later and was confirmed as a case. And a person that he met in a business meeting in Beijing subsequently was also confirmed as a case. And so the transmission must have been pre-symptomatic, with the caveat that, of course, that the businessman from Wuhan might not have told the full story about when his symptoms began. But there were quite a number of these anecdotes. And when we looked at the data from China, we actually found something interesting, that there was a lot of support for infectiousness before symptoms began. In this particular paper that we published in Nature Medicine, we estimated that about half of transmission was occurring before symptoms began, or about half of infectiousness anyway. But then with this particular study, this was after there were quite aggressive control measures, and post-symptomatic transmission was being suppressed by rapid identification and isolation of cases. So I think in Hong Kong, we won't have seen as much as half of transmission being pre-symptomatic, but there is plenty of evidence of pre-symptomatic transmission in Hong Kong as well. One of the, my final slide on China, one of the other interesting things that we looked at was the serial interval distribution. In epidemiology, the serial interval is the time between successive cases in a transmission chain. So if my wife got COVID, passed it to me, and her onset was a week ago, my onset's today, that's a serial interval of 7 days. And we need to know what the serial interval is if we want to understand how fast an infection is spreading. When I gave the estimate of R0 on the first slide from the epidemic in Wuhan, we needed an estimate of the serial interval, which was 7 days in that case, to estimate the reproductive number. And in Hong Kong, we're using the serial interval to estimate the changes in reproductive number over time. What we found in mainland China is that serial interval is actually changing. Many people have thought of this as a kind of biological constant, like the incubation period, that if you have that distribution, you know what it is, it's going to be similar different times and in different paces as well. And it turns out the serial interval actually changes. And the reason for that is because if we stop post-symptomatic transmission by identifying cases very effectively, if we prevent that from happening, then what we have left is really just the pre-symptomatic transmission. So we saw serial intervals in China drop from 8 days before the epidemic peak to 6 days at the time it peaked because of control measures. down to 3 days after the epidemic peak. And that 3-day serial interval indicates really there's a lot of pre-symptomatic transmission going on and not much post-symptomatic transmission at all. And there are some implications for that, which we're still working through. So when we estimate the reproductive number, we're typically assuming a constant serial interval distribution over time. And if that's not the case, actually the red line on the right-hand side shows there's more dramatic changes in the reproductive number than we might have thought. Still working on how to integrate that, but that was a really interesting study. So the situation in Hong Kong, we're now in our fourth wave. First wave in January and February, which when I go to the beach, I look at the waves coming in. This doesn't look like a wave. It looks more like a ripple in a very quiet pond. But anyway, it's called the first wave for some reason. We have a second wave in March and April, which is really not a really substantial wave either, only about 500 cases, because half of the cases were actually people infected outside of Hong Kong and picked up after they arrived in the city, most cases not being able to spread it onwards. We have a very big third wave, and our fourth wave is still going on, and I expect it to be larger than the third wave and possibly more difficult to control than the third wave. And I'll get into that in a moment. We've been tracking the reproductive number over time since the early days and on our website of the School of Public Health. And the way we do this is just by looking at how the case numbers are changing over time and using an algorithm in combination with an estimate of the serial interval to infer how much transmission must have been going on at different points in time. So a simple way to think about it is if case numbers are increasing from day to day, that's indicating the reproductive number was larger than 1 about a week ago. And if case numbers are coming down from day to day, then the reproductive number a week ago must have been below 1. And actually right now today, we've seen case numbers relatively stable towards 100, I think slightly less than 100 for a few days. And so that indicates that about a week ago, the reproductive number was probably about 1. And if you look on our website today, the reproductive number just dipped a little tiny bit below 1, which is good news. But if the reproductive number was to stay at 1 for another few weeks, that would mean we'd still be having almost 100 cases a day for the next few weeks. And I'm concerned about that possibility because apart from the chance of having all those cases and all those people getting sick, there's also then the possibility of infections getting into elderly homes, again, getting into other closed settings, causing larger outbreaks. So the reproductive number of 1 is the target, but we'd actually like to get it below 1 as we managed in the second half of the third wave and the second half of the second wave, to get it substantially below 1 so we can see case numbers come down quite rapidly. If case numbers from now were to come down as quickly as they came down in the third wave, we'd hope to get down to 0 by Chinese New Year, which is still some way ahead. One of the most interesting observations that we've made in Hong Kong was mentioned by Maria Van Kerkhove at the beginning, and that's the clustering in cases locally. This particular analysis is from the second wave. We've repeated the analysis on the third wave, and the findings are very similar. What we find is there's actually a lot of clustering of infections. And so these are the clusters in the second wave, the Barambang cluster, the wedding cluster, the temple cluster, so the first and second wave together, the temple cluster at the bottom, in the middle, and on the right is all the other clusters. And from all of this very detailed data, we can estimate what's the degree of over dispersion or the degree of variability maybe in transmission. So I said at the beginning that the reproductive number of COVID is about 2 or 3 if we don't do anything. In Hong Kong, we've been monitoring it changing over time. Sometimes it's been higher than 2, sometimes it's been lower. But that number's an average. It's an average. So that doesn't mean that every single case infects 2 other people. Actually, some cases would infect more than 2. Others would infect less than 2. And when we look at the data in more detail, on the left is our serial interval distribution of 5 or 6 days. On the right is the interesting one. This is the offspring distribution. So for all the cases, we can say, well, we can estimate how many people did those cases infect. And what we find is that most cases in Hong Kong in the first and second wave didn't transmit infection to anyone else. 70% of the cases didn't transmit to anyone else. And they had opportunities to transmit in many cases. It wasn't that they were already in isolation or quarantine. We've heard from Albert that there are a lot of cases picked up in quarantine, but not the majority. We then see on the right-hand side this long tail that a minority of cases are responsible for a lot of secondary transmission. And we estimated with a statistical model that 19% of cases were responsible for 80% of transmission events. This is the first and second wave. We repeated it for the third wave. I don't have a slide, but it's the same. I think it was 18% of cases responsible for 80% of transmission events. And in the fourth wave, I think we're going to see the same phenomenon again. And it was similar for SARS in 2003 in Hong Kong as well. So that's really interesting. It's called super spreading. It happens for some infections more than it does for others. And it's not completely clear why we have these super spreaders or super spreading events. Certainly, we can't just blame the cases as the super spreaders. There's also the context of where they are and the opportunities for transmission. At the same time, it's not just the circumstances. If we have one case that goes to a bar, maybe they would be a super spreader, maybe they wouldn't. There's also some characteristic, there must be some characteristics of individual cases that make them more likely or less likely to be potential super spreaders. Maybe higher levels of viral shedding, maybe their behaviors, maybe something else that we don't fully understand. And of course, the behaviors of the people around them. While I'm just on this topic, I'll mention one other interesting thing which we can observe from these figures. So all of these circles are cases, and the lines indicate the transmission chains. So we can see in some cases from the bar and bang cluster, there's the initial cluster, and then there's people infected by those cases, and then by those, and then by those. So this pink one, panel A, top, middle, pink, there's a series of transmission with a fourth generation. Some of these, and the color of the circles indicate the location where we think transmission occurred. The boxes that you see around some of the circles indicate people that were in quarantine. And so the idea of quarantine is that maybe we can't isolate cases quickly enough to stop transmission, but we can get ahead, find the people that may have already been infected, put them in quarantine, so that if it turns out they have been infected, that'll be the end. It's like a fire break in a forest fire. You get ahead of the virus in this case with quarantine, and you stop onwards transmission at that point. So we do see a lot of terminal nodes in quarantine. We see a lot of people, a lot of cases in boxes, meaning that they were picked up in quarantine and there was no further transmission because they were quarantined. And that was a success for quarantine measures. But we also see a lot of circles that were not in quarantine, meaning that that person was already the terminal node before they didn't pass it on to anyone else, even though they weren't picked up in quarantine, even though they weren't quarantined maybe before their symptoms began. So that tells us that quarantine is important, but also maybe because of the super spreading phenomenon, it's not essential. Many chains of transmission will naturally die out anyway. What we have to prevent is the super spreading events from occurring. And there's just one last thing, one very interesting phenomenon. If you look in panel A, bottom right, there's a square with a 1 around it. That's what we think is evidence of pre-symptomatic transmission. It was a case that it was a person that was put into quarantine, we think without symptoms when they were put into quarantine. They subsequently developed symptoms or were identified as a case, but their wife had been infected, presumably with pre-symptomatic transmission. So it was the only situation that we were able to identify in the first and second wave where quarantine wasn't quite enough. And I know there's been a discussion in some other countries about quarantining contacts of contacts to go even further ahead of the virus. And the quarantine in the contact of a contact would have prevented this particular case, but that's just one out of thousands of cases so far. So it may not be necessary to go to quarantine in contacts of contacts. But it's an interesting observation here that there was this possibility that the transmission chain could continue even though quarantine was being used. So I mentioned that quarantine is important. The data shown on this slide is the onset to confirmation delays. That's how long does it take between when someone has symptoms and when they're confirmed as a COVID case. And in the second wave on the left in March, in the third wave in June and July, we see confirmation delays for imported cases at the top, the local sporadic and inner cases, and then the local secondary cases are quite long, often 4, 5, 6, 7 days, and not coming down very rapidly. And so we'll use this as justification for the contact tracing and the quarantine. We know it's really important to identify cases as quickly as possible and to isolate them in hospital as quickly as possible. But because we know that COVID cases, if they are contagious, they will be contagious mostly around the time their symptoms appear, a few days before, a few days after. And so if we isolate them on average, day 5 or day 6 or day 7 of their illness, that's a little bit too late to stop onwards transmission. And we really need to use that contact tracing and quarantine to get ahead of the virus and to stop chains of transmission and use that targeted approach to slow down the spread of the virus in the community. So this kind of data really emphasizes the value and the importance of contact tracing, not only isolation, but also contact tracing and quarantine. When we have an infection with the super spreading phenomenon, there's 2 interesting implications that maybe haven't been discussed enough. Firstly, if we identify early signs of super spreading events, then focusing our contact tracing efforts on those particularly should be protective. So I could give some scenarios. If we find a cluster of cases maybe linked with a household and a particular case, then that's obviously a concern. But tracing all the contacts of that particular case who maybe infected their household members may not be our highest priority compared to if we hear about cases linked to going to the same bar, working in the same office, where there's a potential that there could have been a super spreading event. And by identifying all of those close contacts and quarantining them, maybe there'll be much more yield. And we can have early estimates of how big super spreading events might be, just thinking about the incubation period. If we think there was a super spreading event a few days ago in a bar, and we've already seen 10 cases, we can be sure there's going to be a lot more, because most incubation periods are longer than 2 or 3 days. The other interesting implication is that if 80% of infections really are acquired from 20% of cases, then going backwards from infections will help us to identify super spreading events. So often when we think about contact tracing, we think about going forwards to get ahead of the virus. We'll find cases and we'll go ahead to see who might they have infected, put those people in quarantine, and by doing that, we'll stop the virus from continuing to spread in the community. But actually going backwards could really be valuable as well. And I know it's being done here and in some other places. The concept is, if 80% of our infections, if 80% of our cases today were acquired from 20% of some previous cases, if we can identify where those super spreading events occurred, where those infections were acquired, maybe we can find a whole lot more. And actually, when I look at the number of unlinked cases in recent days in Hong Kong, I worry that there have been super spreading events we haven't yet identified. And maybe once we do pick up some additional super spreading events, we'll suddenly discover a whole lot more cases again. A little bit like the dancehall cluster. Initially, it seemed very small, but once there's an investigation, suddenly there's tens and then hundreds of cases. So backwards contact tracing can be really, really valuable as well, really important as well. And I know I'm going to talk in a moment about the impact of government measures in controlling COVID, but I think that's only one part of the story. I think population responses have been really, really important. We've been tracking population responses every week since May with regular telephone surveys. Each survey has either 500 or 1,000 people, and we'll ask a whole lot of questions in these surveys. So on this slide, I'm showing people's perceived severity of COVID-19 in green, their worry about being infected in blue, and that spikes every time there's a local epidemic wave, and then their perceived susceptibility as well. So there's worry and there's perceived susceptibility. The susceptibility goes up a little bit more. The red one goes up a little bit less than the worry. The perceived susceptibility goes up a little bit less than the worry. People are really worried, and that makes them change their behaviors. So in terms of the behaviors that we looked at, we've got here in red, avoided crowded places. In purple, avoid social gatherings. In green, avoid going out as much as possible. And in blue, avoid healthcare facilities, which is an unfortunate consequence as well of all the social distancing measures that people often now miss their medical appointments and don't want to go and see the doctor. And each of these avoidance behaviors has been coming down between waves and then spiking and going back up again during epidemic waves. Jumped up during the 3rd wave, now jumping up again during the 4th wave. And it's reassuring that people are willing to change their behaviors. And I think it's been really important. It's been a really important factor in stopping the 2nd wave and the 3rd wave, and it's going to be important again in stopping the 4th wave. We also ask about mask and hand hygiene. So the red one at the top is the face mask use, wear masks when going out. We've seen ourselves it's almost universal masking, and it has been even before universal masking was mandatory. The other measures have been pretty high throughout, and some of them increasing a little bit as the risk increases with local transmission. I want to mention masks briefly, since I'm here and I have done a little bit of work on face masks. We still don't completely understand how COVID-19 is spreading predominantly. There's still controversy about whether the fomite route is important, whether there can be contamination of surfaces. There's some anecdotes about transmission that could be explained by fomites, but no really compelling data on what's the frequency of the different routes of transmission. There's particular controversy about aerosol transmission. So that means transmission in the fine particles in exhaled breaths or coughs that can carry viruses. And there's often a reluctance to allow for the possibility that aerosols can be involved in the spread of respiratory viruses, whether it's influenza or coronaviruses. One of the arguments against the aerosol route being important is the argument that we don't see a lot of long-range transmission. That's true. But actually, if aerosols are responsible for some transmission, we'd still see most of that at close range. We'd see it in prolonged contact, close contact, not necessarily face-to-face, but in the same room for a longer period of time, not necessarily at long range because of the dilution over longer distances. We did a study in Hong Kong a few years ago, not very, very recently, on how well face masks can block larger droplets and also aerosols. And the results are kind of interesting. So here, I'm going to have a few slides like this. On the left is the virus we picked up in the nasal swab. In the blue is the throat swab. And then in the first red box is the large droplets without a mask and the patient's wearing with a mask. And then the right-hand side is the aerosols. The final box on the right side is the aerosols in patients without a mask or with a mask. And what we saw for influenza is that there was reduction in patients shedding virus into the environment in both droplets and in aerosols in people wearing masks. The aerosol result was not significant, but we have another study in the US that shows it is significant with very similar magnitude reduction. So the surgical masks really work for influenza as a source control. And for seasonal human coronaviruses, that's common cold coronaviruses, the masks work as well, even for aerosols. And so it's really, really useful that everybody's wearing masks. That means even people in Hong Kong who are infected without symptoms, if they're wearing a mask as well, that's going to capture some of the virus that otherwise would have been going into the environment. And that's a really effective source control to reduce the risk of transmission occurring in the community. We would expect masks to have a similar effect on COVID-19 as they have on influenza and human coronaviruses. But there was one interesting result in this paper which I wanted to show you. And when we looked at rhinoviruses, we didn't see an effect of face masks. Actually, in the middle panel on the right-hand panel, you can see there's a lot of virus getting through the masks. And this was in very controlled situation. At the time we did the collection, we didn't know what the patient had. We were just collecting all the samples anyway. It's only later when we took them to the lab, we found out this patient had influenza, that patient had rhinovirus, whatever. So there wasn't a bias because of the timing or the style of the study being done. We can compare these with the coronavirus and the influenza data. And it's weird. It looks like face masks don't really work very well for rhinoviruses. And the reason I'm showing it now is because you remember we had all these outbreaks of rhinoviruses in kindergartens and primary schools, despite universal masking. I thought that the universal masking was going to stop all the common cold infections. It didn't stop rhinoviruses. And I wonder whether there's something about face masks, about the size of the particles, I don't know, that contributes to that. Of course, in kindergartens, the kids don't wear masks as well as we do, and rhinoviruses can survive in the environment reasonably well. So it's not only about face masks, but I'm interested in how do we have so many common cold outbreaks in young children, despite universal masking in schools that was done to a reasonable standard. I really like the Wipro recommendation to avoid the 3 Cs, avoid crowded places, avoid close contact settings, avoid confined and enclosed space. I think we've been doing a good job of that in Hong Kong. I'll mention that each of these does account for the possibility that the virus is being spread at close range by aerosols. And as I've shown, face masks can help to prevent that. So I think going forwards, these may be the most important kinds of preventive measures that we can think about. We don't necessarily need to look at all the measures that have been used in Hong Kong, but these particular measures to avoid crowds, avoid confined spaces, with crowds, especially with prolonged close contact. That's going to be really, really vital in controlling the fourth wave now and subsequent waves. When we look at what was done to deal with the second wave and the third wave, it's really difficult to piece together which of the measures were most important, but I want to highlight a couple of points. So we had a second wave in March and a third wave in July, despite very high use of face masks. So it's clear that face masks were not sufficient. Of course, we know that face masks help, and if we were not all wearing face masks, the situation would be worse. At the same time, though, we know that we need more than just wearing face masks. And when we've analyzed where transmission has been occurring in Hong Kong, we think about 70% or more of transmission has occurred in mask-off settings. That means households, it means restaurants, bars, some other settings, some other workplaces where masks are not being worn, and some like residential care homes for disabled, maybe some elderly as well, where mask use is not really very high. So that's interesting. Masks do work. If we were not all wearing masks, there'd be more COVID for sure. But at the same time, we can't rely on face masks to bring an end to the fourth wave. And the same for test and trace. It's really important. Albert showed that 25% of cases have been picked up in quarantine from contact tracing, from contact tracing, including people in quarantine. So that's definitely helping to stop those people from being able to spread it, but it's not enough either. And when numbers of cases get really high, I think the test and trace gets more and more difficult. So what has worked? I put the measures in orange here, the social distancing measures, the civil service working at home, the reductions on mass gatherings, the closure of bars, nightclubs, karaoke leisure facilities, and the restaurant restrictions as well. They were all implemented together to deal with the second wave, and so we can't tell which of the measures was really most important. And then the third wave, all implemented at pretty much the same time. So again, it's really difficult to know which of these measures were the most important. My personal opinion is that reducing the mass gatherings and closing the bars, nightclubs, karaoke's would be relatively the most important, because those are the places we've seen super spreading events occur. And I think if we can stop or slow down the occurrence of super spreading events, that would make the most difference. Those would be the most cost-effective measures, in my opinion. Even though I know there's economic implications of those measures, I think those are the kind of measures we need to deal with COVID. So I've said that. I'm coming to the end now, but I want to make a few comments about children. We know that severity of COVID increases dramatically with age. And as Albert presented, 90% plus of our cases, of our deaths are in the elderly. We know that COVID is typically a mild infection, even in older adults, actually. The case fatality rate is not particularly high. Here we've got fatality rate of 6% in people over 80. So that means 94% not fatal. And of course, in younger adults, it is really very, very low fatality rate. Also, it seems like children are less susceptible to infection, particularly younger children. It's not clear why. Sometimes they can still get asymptomatic infections, but it does seem, this study, that the data published here were from very early in the epidemic, but I haven't seen anything that's really changed this picture. The infections are really mild, very mild in children, and also children seem to be less susceptible. So in Hong Kong, in June and July, schools were open for a period of time when there was COVID in the community, and then they were closed as one of the response measures to the third wave. We looked at whether there had been any evidence of outbreaks in schools, and we couldn't see it. We identified 15 cases in children where there could have been opportunities for transmission in schools. We don't know all the details. Maybe in CHP you know more details than we know, but we looked into them as hard as we could. 15 cases in children where we thought there could have been an opportunity for transmission in the school. And we didn't find any evidence of other cases or outbreaks in those schools, probably because of the very stringent measures that were put in place before schools reopened. And those are listed on the slide: the temperature checks, the universal masking, the half-day school, so there's no lunch at school, staggering the arrival times and dismissal times, increasing the desk spacing, avoiding the large group activities, and so on. So that really reassured us that it was safe to have schools open in Hong Kong. And in the fourth wave, I would say we've had the same impression again, that when schools were open until recently, with all these measures in place, there were cases reported in school-aged children. Presumably, some of those children would have had the opportunity to spread in schools, and yet there haven't been any school outbreaks. I check the press conferences every day, and I'll often note a pattern that on one particular day, there'll be a report of a case or two in a care home for the elderly, or a case or two in a hospital, or a case or two in another social setting. And the following days, a lot of cases get reported from those. It turns into a big, maybe there's a big outbreak after all, in a care home for the elderly, in some workplaces, in some other settings. But then when it comes to the school cases, we've heard many, many reports of cases in schools and then the school being closed. And I've never heard of any outbreaks being picked up in those schools. And I know that there's been attention on the classmates, on the teachers, to see whether there might be transmission, and no evidence of transmission. It doesn't mean no transmission, but certainly no evidence of transmission. So in my opinion, it's safe to keep schools open in Hong Kong while COVID is spreading in the community. I think that there's still some difference of opinions in different parts of the community about whether schools can remain open, but my opinion is we've done pretty well with schools, and I certainly appreciate the times when my children go to school and not staying at home. We had a mass testing exercise in Hong Kong in early September with 1.7 million people tested, identifying 32 cases that might not otherwise have been identified. Most of those cases were towards the tail end of their infection, already been symptomatic, already recovered in some cases. And so we didn't necessarily stop a lot of onwards transmission with the mass testing scheme, but we did identify that there were some silent infections in the community. Not a lot, but some. And from this data, we've been analyzing it and still working on it, but coming up with an estimate that maybe the case numbers reflect about 25% of the infections so far in Hong Kong. So if there's 6,000 infections, sorry, if there's 6,000 cases so far in Hong Kong, our estimate would be something like 24,000 infections, something like that. So just multiply by 4. We're picking up 25% of infections as cases. So that's good news and bad news. Certainly we know that the mild or asymptomatic cases that we're not picking up probably is not essential to identify all of those. And maybe those are less contagious than the symptomatic cases anyway, the more heavily symptomatic cases. Also, we know because of the super spreading phenomenon, most asymptomatic cases and most mild cases in the community will not pass on an infection anyway. And as long as we keep an eye out for super spreading events, then actually we don't need to worry. When we see low case numbers from day to day, we have a pretty good chance the case numbers are going to drop to 0, like they did at the end of the third wave, even though we dropped the control measures, just because most cases don't spread. So I'm coming to an end. I've shown data and talked about how face masks and test and trace are definitely really important, and they've been helping us a lot in Hong Kong to stay on top of COVID, but we do need social distancing measures as well. Infections in crowded mask-off settings have been particularly important, and I think those crowded mask-off settings are the ones we really need to focus on in dealing with the 4th wave and any subsequent waves in Hong Kong. The control measures that were implemented by the government were sufficient to control the 2nd wave and the 3rd wave, but I did make the point in my talk that I think personal behavioral changes are also critical to that. I don't think it's only because the government did these measures that we got the epidemic under control. It's because people complied, people changed their behavior, that really case numbers were able to come under control. It's going to be really important to prevent imported infections if we get down to 0. And I'm still not completely clear about the long-term strategy. I know we heard about the suppress and lift approach, which means like we did in the 3rd wave, we keep control measures in place until case numbers go down towards 0, but not necessarily 0 for a period of time. And then we lift the measures to let everybody relax. There's a different approach being used called eradication or elimination. And in that approach, in that model, we need to keep the measures in place longer once we get down to 0. So if we go for that after the 4th wave, we might see the social distancing measures in place even after we've reached 0, maybe for another 2 weeks or 3 weeks to really be sure that we've got infections out. And if we go for that, then preventing imported infections will be really, really critical. If there are imported infections coming into Hong Kong today, a handful of imported infections, I don't think it will make a lot of difference because we already have probably 100 local cases and then other infections that aren't being detected. But if we get down to 0 and then we have imported infections coming in, that's going to spark the 5th wave. And the final hope is that we can get back to normal through mass vaccination sometime later in 2021. I'm not sure exactly when. It really depends on how much vaccine we can get and how soon we can get it. And when we all decide that enough is enough and we're going to get back to normal because at least the most vulnerable groups and healthcare workers have been vaccinated, perhaps. So I'll finish there. Thank you.